Welcome to the podcast for Healing Neurology, where we talk about everything that can help heal your neurology, which is really everything from food, lifestyle, and medicine to nature, culture, and politics. There's no topic too big or too small. I'm Jillian Ehrlich, family nurse practitioner, certified in Ayurveda and functional medicine. And we have an incredible guest today, somebody I very highly respect and appreciate, Dr. Sharad Kohli. And he has dedicated his career to advancing health justice. After completing a rural family medicine residency, he has spent close to 2 decades working with federally qualified health centers in both urban and rural settings in California and Texas. He previously served as the Director of Clinical Affairs of the Texas Association of Community Health Centers, where he provided clinical support to the more than 75 FQHCs throughout the state. Dr. Kohli currently works at People's Community Clinic, an FQHC in Austin that strongly believes in looking upstream at factors that influence health. At People's, he has spearheaded the development of a nationally recognized interprofessional pain management program that integrates numerous services, including behavioral health, acupuncture, yoga therapy, nutrition, substance use treatment, and a medical legal partnership, group medical visits, and more. So that's what we're going to hear about today. Very excited. Dr. Kohli was a key figure in the growth and development of the national nonprofit Integrative Medicine for the Underserved, which is IM4US.org for more information about that organization. It's a multidisciplinary organization committed to health equity and justice through culturally responsive, accessible, and integrative care. He's an affiliate faculty member in the Department of Population Health at the University of Texas at Austin Dell Medical School, a member of the Board of Governors at AOMA Graduate School of Integrative Medicine, and he's a board member of the Integrative Health Policy Consortium. He's also married to a naturopathic physician who inspires him and from whom he learns daily. Dr. Kohli, welcome. We're so glad to have you.
Yeah, thanks for having me. This is great to be here.
So as we talked about in preparation for this show, what I'm most interested in is hearing your story, because it's a pretty incredible story of how you evolved as a physician. So let's go back to you go through medical school, you come out of medical school, you're a doctor, and then what happens?
So, it's interesting because I think when I went to medical school, I came into it with a little bit different perspective already. I mean, my family is from India. So already we were, utilizing things like Ayurvedic medicine or yoga or other natural type health practices in our household. But at the same time, my mom was a physician. She was a pathologist. And so was very, very much encouraging me to go into medical school. And so we had this sort of integrated household, right? We weren't afraid to use, traditional medicines from India, but also obviously pharmaceuticals and such. So when I went to medical school, and I was, interestingly, I was actually interested in probably going into some sort of specialty or something when I first started. But I went to medical school in Oklahoma, and I learned a lot about rural family medicine there because they're trying to promote, doctors going back into the small communities and working. And so I decided family medicine was what I wanted to do. And I ended up basically doing a rural family medicine residency in Southern Oregon. And when I did that, actually in between my first and second year of medical school, I did this big road trip around the country, and I drove through the Northwest, and I actually was in Seattle where you're at. Mm-hmm. And I was at, I think it was the Pike Street pub or whatever. And I was talking to the waitress there, and she's telling me that she's about to start naturopathic medical school at NCNM in Portland. And so I was like, well, what's that? And so she started telling me about naturopathic medical school. And I was just like, oh, wow, that's focus on prevention and letting the body go back into balance and using all these different healing traditions from all over the world. And I was like, that's actually what I'm more interested in. But I'm already a year into this schooling. So that I don't know if I'm going to turn around and turn this car around at this point. So, but interestingly, I ended up going to I told a friend about it, and he got really excited, and he ended up getting into school at NCNM in Portland the same year that I was going to residency in Klamath Falls. So I would go and visit him all the time, on my weekends off or whatever. And so I got to start hanging out with the naturopathic medical students. And so I started learning what they're studying and realizing, wow, this is they have all the same knowledge that we do, but then they get all this extra training in nutrition and in, mind-body techniques and, acupuncture or craniosacral or all these other things. And I'm just well, this is great to know about, And then I ended up trying, applying some of these concepts, some of these things I was learning from them, with my patients in residency. But when I got out into the real world, at that point, I actually started dating a naturopath at that point. So
You did love naturopaths.
yeah. So, and she's my wife now. So, so I started like really like getting more interested in these things. And I always was interested in nutrition and lifestyle changes and these sort of things and talking about these with my patients. And so a couple of years out of residency, I was living in the Bay Area, and I was like working with patients, and I always worked in federally qualified health centers. I was always interested in working in underserved clinics because I can work in a private practice. There's plenty of docs who go to private practice. I definitely felt like there's a need in these communities, and I wanted to kind of work there. And so, I talked to a patient, and I was living, this is in the Bay Area, and I was just talking to them like, okay, well, for your hypertension, you need to exercise and eat healthy. All right, good. Patient leaves, comes back like a couple months later. Nothing's changed. Have you been exercising? No. Have you been eating healthy? And so I'm asking like, well, what about this? And like, well, I don't really have access to healthy foods. Like I live in the neighborhood. All I have is a corner store. There's no fruits and vegetables there. I can't really exercise. Like it's not safe. Like people get shot in my neighborhood. Like I can't just go out and go for a jog or whatever. Right. Mm-hmm. So it just started me thinking about like, okay, well, there are all these things, like even though I want to talk about these things, there are just all these other structural barriers that prevent people from actually being healthy. And so, we started really thinking about that in our clinic, and we were already, kind of moving towards these models of FQHCs, I think, if you're not familiar with FQHCs are federally qualified health centers, and they started from the war on poverty and the civil rights era, and essentially were in communities of color that didn't have access to healthcare. And there were places where you can, it wasn't just for healthcare though. They also provided like food and education and places to learn about voting rights and just kind of other things within the community that could help people be healthy. And so, our health center all provided some of those services, but we started really thinking about like, what are other things we can do? Well, could we start providing access to healthy foods in our health center? Can we give away foods? And so we started creating like programs where we worked with farmers markets to get like extra food and then donate that to our patients essentially. Mm-hmm. And then we started putting together healthy recipes, and then we started creating spaces to exercise in the clinic so that it would be, so people could actually have a safe space, Mm-hmm. And then, for a lot of our patients who were lonely and isolated, we do it a lot with group visits where we would bring people together to kind of learn about their conditions. And we can talk more about that later, but essentially trying to do things to kind of like address some of these social needs that patients have. But I think as we started doing a lot of this stuff, I got kind of connected with a few folks in other FQHCs who were doing similar things. And, we also were like, my clinic had a very diverse patient population. We saw people from over 60 different countries. So thinking about like, some people really were already interested in other forms of healing, whether that's herbs or like mind body, other things like that. And so we would incorporate these things. We would incorporate acupuncture for our patients. Like we had a large South Asian patient population. So we brought in an Ayurvedic practitioner who started working with our patients. And we brought in yoga, so I met other people from other different FQHCs, and we kind of got together and decided, hey, we need a conference to sort of like just share this, because most of the integrative health conferences were not geared to like our patient population. So we formed, the Integrative Medicine for the Underserved conference. And, a lot of it was just out of this desire to like take better care of our patients and share these best practices. But as we've developed that organization, and this, over the 10 years of that organization, we started realizing, okay, well, we can individually work with our patients, and that's really important. And that's really important for those patients to kind of prevent disease or, deal with their chronic illness. We can give them some of these things to help with their individual social needs and connect them to the resources in the community. But there's still these bigger, deeper upstream factors that are at play. And so we had to focus on equity issues and systemic and institutionalized racism. And so we kind of became an organization that's really focused on racial justice, and then also policy, because that all it happens through policy. Like it's these policies that like lead to poor health in especially BIPOC communities, right? So, so we sort of grew, and that organization has now sort of become a sort of this like bridge between the integrated health world and the social justice world in some ways.
Why is doing political work so imperative in communities that are traditionally marginalized by society and medicine? Like, what does political work look like as a physician?
Well, I don't think this only applies in marginalized communities. I think it applies in all communities, actually. But I think marginalized communities are more impacted by the policies that have happened. And the policies have happened to keep marginalized communities down, right? Like, so whether it's like lack of expansion to healthcare, like Texas is a perfect example. Like, we didn't expand Medicaid. Well, There are reasons we didn't expand Medicaid. It's mostly the South that didn't expand Medicaid, right? So
Mm-hmm.
the people who would access Medicaid are people who've traditionally been discriminated against for many, many years here. And so there are lots of different policies over the years that have really impacted a marginalized population and led to health disparities. So I think if you're only, I mean, this is what we found in IM4US, if we're only just dealing with the people on an individual level and helping them, I mean, it's important, like, whether it's building resiliency so you can kind of like, I mean, if you don't have sick days at your job, you don't want to get sick because you're going to lose out on income. You might get fired. How are you going to care for your family, right? So you have to stay healthy. So that's part of it. But we have to also work on the policies to get people sick days, right? And I think this applies with all the clinicians. I think that, if our goal as a clinician is to create well-being for our patients, we have to actually look upstream, like we have to be an advocate for them. And we have to look at all the factors that are influencing health, right? So I mean, that could be systemic racism or state-sponsored violence, could be gun violence, right? Like we heard about like the NRA complaining about doctors who are like talking about gun violence, stay in your lane. Well, this is our lane, right? Like this impacts us, right? Those policies impact our patients. Could be the environment or food system, criminal justice system, education, immigration, everything, right? Like it all ties together. And so we can't just ignore these issues. We can't just say like, well, I'm just going to give you your hypertensive medicine and like you're good to go. Well, what are the reasons people have hypertension? Well, a lot of it tends to be because of chronic stress, increase in cortisol levels. You can tie that in certain communities, whether that's to discrimination and racism, whether that's to poverty, all these other bigger factors. And so you have to kind of think about these things at the very least. I mean, people can get involved at different levels, but I think like we just can't ignore them. So there's a growing movement to get clinicians more involved in advocacy. That could be through your, whatever you think of your state medical organization, which I don't think always highly of the state medical or the AMA. They actually have a sort of a system to kind of advocate for whatever issues are passionate for you. So you could kind of do that to be able to like talk to legislators. You can present and speak about these particular issues. You could talk to your reps. Actually, that's the other thing that's really interesting. Like I've always really was intimidated about talking to like my senators, to my senator or representative. The reality is you're not going to talk to those people anyway. You're going to talk to their staffers. Their staffers are generally like in their like 20s who are looking for a free meal, right? And so like you're actually an expert. They're kind of interested in you. Like, if you give like a briefing or something and there's food, they'll show up or whatever. And so like the more the times I talk to them, I'm like, I'm not really that intimidated because I actually know a lot more about this stuff, but they're actually interested to listen to you. So that's one thing. An important one I think would be writing letters during periods of public comments for rules and like for particular agencies. So an example of that was like HHS, Human Services, had a new report on pain management, and there's a period of public comment for like 90 days before they would publish this, right? And so the report was actually really great, like, and it's actually come out, but it basically like focuses on a lot of non-drug approaches to pain, et cetera. And so initially there was like all these comments coming in from people like the pharmaceutical industry and from people who really were afraid to lose their medications or whatever. And so I was part of Integrative Health Policy Consortium at IM4US at the time. We kind of started this like campaign where we basically sent email blasts out to our members to say, hey, we need to like flood comments in to HHS. So we just flooded the comments and we actually tipped it from like heavily opposed to this to slightly in favor of it, basically, or more like 50-50. Wow. But it allowed them to like feel justified in releasing that report. Those sort of things actually make a difference. So I think like that sort of thing in terms of getting involved, being advocates is important. I also think the other thing is just like looking at self-reflecting and addressing your own individual biases around healthcare and like what you've been taught, because like what we learn in medical school, it is a very like kind of racist colonial system in a lot of ways. So we don't always treat BIPOC patients with the kind of respect and dignity that they deserve. And so, Black, Indigenous, and people of color. So I think it's really important to sort of like reflect upon your own individual bias. We all have biases and kind of think about that. You can just go to your job and just hand out prescriptions and that you could do that if you want. And maybe, ignorance is bliss, I guess. You don't have to think about the problems in the world. But I do feel like, I feel like if we're part of our responsibility as clinicians is to do whatever it takes to like really advocate for our patients and really look at especially in the integrated health world, if we're really talking about looking at root causes, it's not just like, are they eating kale? Like it's go deeper than that. Right?
Yes, this is not just a kale deficiency.
Right. Right.
One thing I think a lot of clinicians struggle with is time and time management. And so what I'm wondering is what you're talking about sounds like, it can take a little time or it can take a lot of time. But what role do you think this extra time investment has had on your individual burnout or lack of burnout?
I think it's very easy to burn out in healthcare, as we all know, right? And so, yeah, you might think like, okay, well, if I add this on, am I going to burn out more? And it's true, yeah, but you have to kind of decide what you want to do. Like for me, I've decided over time that I actually am going to work less in clinic. I like patient care, but I also like systems level thinking. So to me, like creating systems to kind of make our clinic more efficient, to kind of think about how we can be advocating in different ways, those sort of things are important to me. And I think when I do those sort of things, it helps feed me a little bit more. It makes me, less burned out in some ways. I also think that like, and this is common in the integrated health world too, like people take on extra training, they want to do everything. And that's just a recipe for burnout, right? Like I could easily go and like learn acupuncture. I can learn Ayurveda. I can learn all these different things and incorporate those in. But like, that's not going to, I'm going to just feel like I'm taking on too much in that situation. And I'm not going to do it as well as if I had brought in an acupuncturist or an Ayurvedic practitioner or whomever, right?
Yeah.
So to me, I think part of it is building a team and really working in a team with a team approach. And that's kind of what we built at our clinic. I mean, we have an integrated pain management clinic, and, we have a team, and we all bring our expertise in, and we all we've create these case conferences where we discuss the patients, and it sort of like flattens the hierarchy also, because we all are just working together and trying to figure out like from our own perspectives, what can we bring to this case. And so we have, we have a physician, we have social worker, we have a substance use counselor, we have a nutritionist, we have an acupuncturist, we have a yoga therapist, and then we have a lawyer because we have a medical legal partnership, which is really, really important, especially in underserved patients who, and especially in Texas, where there are a lot of rules that kind of like prevent people from getting access to healthcare or getting evicted and things like that. So by building a team and working together, we're able to really effectively help our patients out, but also, address our burnout. Like I don't have to do everything. I know that the lawyer is going to handle this, or the social worker is going to handle this, or the nutritionist can talk about this. And, when we talk to members of our team consistently, they say that like when we meet and have our case conferences, those are like the favorite times of their week because like we're all just kind of like learning together.
So can you talk to us a little bit about your pain program?
Yeah, it actually started mainly like, and so again, we're in a federally qualified health center. So when back a few years ago, there was all this money that came out addressing the opioid epidemic, right? Like trying to figure out ways to mitigate opioid prescribing and help people who have opioid addiction. And so what we decided is that, a lot of people were hiring like, or getting people trained for medication assisted therapies like buprenorphine to kind of help get people off of opioids. Our clinic didn't have a huge opioid problem, which is great. Like we have a lot of patients with pain, a lot of patients with complex trauma, but just, whether it's culturally for our patients or our practitioners, we just haven't been giving a lot of opioids out, which is good. But there are a lot of people who are at high risk of developing a substance use disorder because of previous trauma and because of, the chronic pain that they experience. What we decided to do is we were going to use that money to create essentially an opioid prevention strategy, which is creating an integrated pain program. So we decided we're going to try to get people in, and we kind of, this was before that HHS document that I referred to, but like I had some experience building something similar through my previous FQHC in California. Through I Am For Us, we've been talking about all these things for many, many years. So just gaining that wisdom and being able to utilize it. And so we just kind of, looking at my clinic, like we had a lot of these resources in play. Like we already had the medical legal partnership and the nutritionist and the integrated behavioral health. We had acupuncture through AOMA, which you mentioned earlier, is a Chinese medicine school here in town. They had been sending students since like 2003. So we had that there. And so what we were able to do is just kind of like pull it all together and create a program. And we were able to add in more hours of acupuncture. We added in a yoga therapist. We were going to add in massage therapy, but then when COVID hit, we couldn't actually bring the massage therapist in. But we also hired a care coordinator to kind of pull it all together. And so what happens is patients who have chronic pain, and again, like a lot of these patients that we see are like, fibromyalgia, complex trauma. Like we have our patients population is about 85% Latinx. And a lot of them come from like Mexico or Central America. A lot of them are fleeing violence and, are coming as refugees. And so have experienced like a lot of trauma. A lot of our patients who live in East Austin have also experienced trauma in their communities, which is a very underserved population. So we just have a lot of trauma, and emotional trauma, emotional pain lights up a lot of the same parts of the brain as physical pain, right? So whether they have physical pain or emotional pain, it's similar approach. So a patient will come in and essentially get referred to our pain program. So they'll see like a PCP that refers them to the care coordinator, and then the care coordinator will tell them about the different options we have. So a lot of times our patients will start with like counseling with a behavioral health specialist, or if they have like a legal issue hanging over their head, like let's say they don't have insurance, but they probably would qualify for disability, and maybe they applied for disability, it was denied. Well, a lawyer can help them get on disability. And once they're on disability, then they get access to insurance, which most of our patients don't have insurance because we're in Texas. And so then they can get to see, get their imaging or see an orthopedist or whatever, or they can even get like an income with that. So that like also takes a level of stress off their plate, which then can help their pain a little bit. But then we can refer them to the nutritionist, we can refer them to the acupuncture, the yoga therapy, whatever. But like really the key to this program is our group medical visits. So we do chronic pain groups, which we got the curriculum from a physician out in Massachusetts, Paula Gardner, who'd been doing these integrated medicine pain groups through Boston Medical Center, where she was at the time. And so we kind of like took that and just adapted it to our population. And they're basically 8-week groups. And we just kind of have more time to like spend with patients. So group medical visits, if you're aware, are essentially these where patients get their medical care in a group. And it's kind of this new value-based model because you can actually bill for the visits because it's one-on-one component with the provider. But really, you have much more time for like education and self-management and just kind of like doing some mind body practices or like learning to cook or really, but the biggest thing is that you build community. People connect with each other. People who may be isolated and lonely, whether that's physically isolated and lonely or isolated because maybe they're the only person in their house that has chronic pain and no one really understands their pain. They can connect with other people who have gone through the same thing. And so people who have pain for like 30 years are connecting with people who've had it for 5, and they're like forming like a mentorship in some ways. And so these groups, people are just like learning from each other and they're connecting with one another. And it's funny because we had a medical student who recently was doing a qualitative analysis of our program. And she's just finding that consistently the people who've gone through groups just understand their pain much more better and understand how to manage their pain so much better than if they were in the program and just like, doing acupuncture, yoga therapy and things like that. So we kind of like built this program and we just kind of like, and it's limited because a lot of it's based on this funding that we got from the grants, but we're trying to figure out how to like expand it. And is there a different payment model that we have to use? Can we talk about it? Because complex trauma and complex chronic pain, you can't just work on a fee for service basis. You have to actually think about maybe a bundled payment or something so we can actually expand these sort of.
So do people, after the groups, do people stay connected?
That was been like our goal was to kind of create these alumni groups once people graduated from those 8-week groups. And we were planning on starting that, but then as usual, COVID hit and that kind of ended those. Some people do. Some people share phone numbers and still talk to another. We've had some people join our newer groups. Like people from the old groups still want to come back. So they have 2 people from the old group who've like repeating. And so then now they're seeing each other again, like, hey, how's it going? Because they're on Zoom now, right? So they see them on the Zoom and like wave or whatever. But yeah, I mean, our goal was to actually have people, because we identify people who are probably would be good leaders in those groups, right? Because that just naturally comes forward. And so it's like, well, what if that person was like the peer leader? And then maybe you have some support from a staff member. And that's still in the plans. I think we want to kind of try to expand that and continue like peer support essentially.
Healing through groups is not how we typically either think about going to the doctor or think about our responsibility for our health, right? And as before the call, we were talking about that there's different styles of thinking about medicine and health, and that we have been trained, we here, meaning in the US in the modern age, have been kind of trained that it's an individual problem that requires an individual solution. Can you talk a little bit about some of the other ways of thinking about health and medicine and other?
Yeah. I mean, I think that the training we have is very Western training. It's sort of in some ways a very much a colonial model of thinking. And I think it is, we do focus a lot on, we take a deficit-based approach to health, right? Like we talk about disease all the time, but we don't talk about wellness and well-being as much as we need to. And so there's this movement now about decolonizing medicine, or as my friend Vanessa Quezada says, re-indigenizing medicine, right? And actually, like at I Am For Us last year, there was this group called Circles International, and they presented about this, and they had this like really nice chart, which it lays it out nicely, and they kind of talk about this. And so I kind of have the chart there. I can kind of explain, but basically, they're talking about how, like, in our current model, current system, that it's based on the fact that, trauma and ailments, these are like medical diagnoses. These are problems. These are things that you have. And while in like more of an indigenous model of healthcare, when I say indigenous, I don't mean like only in the Americas, because I think if you look at like Indian medicine and Ayurvedic, or you look at Chinese medicine and things that have been around for like thousands of years, they take similar views as well, that these things are like, universal human experiences. It's normal to have trauma and ailments. And so part of it's your body just going out of balance. And so you want to heal and bring yourself back into balance. So instead of being like a linear process, it's more of like the circular process, essentially.
And I would say too, which is really good, that, it's not like it's bad when we're sick and we're good when we're well. So I think that there's this value that we place on like health is good, being sick is bad. Like what you're saying is that we're all going to go through inevitable cycles of feeling better or feeling worse, and that nothing is a given and that nothing stays the same. So you're never going to be healthy forever. You're never going to be sick forever. Completely. That you're just going to cycle through.
Yeah, completely.
Right?
I think that's really true. And even when you look at like how we view healthcare, I mean, like I look at this all the time because we always look at grants, trying to get grants, and like the things that they're always looking at are like, well, did the A1C go down? Like, okay, well, let's say someone A1C went from 9 to 6.7. Okay, does that mean their well-being is good? That they're better off than they were before? Maybe, but maybe not. Yeah. And so we have to have a measure of like well-being, like how people actually are they able to do the things that they still enjoy doing, So I think like that speaks to like having different metrics. I mean, we started piloting something called the flourishing measures, which is a quality of life measure that came out of Harvard, and it kind of looks at like, on a scale of 1 to 10, like, do you know what your purpose in life is, or how are your relationships with your community or your family? Like, they kind of go into like different aspects of well-being, essentially. And so I think that sort of thing, we just is lacking in sort of our Western model of healthcare. Yeah. It's sort of like, how do we change that? But yeah, I also think like going back to like the different models. I mean, I think we are a very individualistic society, and so when we talk about health, it's just very much like, okay, this is what's wrong with you. This is how you need to fix it, like, because it's you. But like, it's excluding the idea of community, and community is healing. Like just like being around people, being around family is really a healing thing. And I see it like, in the Indian community, and most communities of color or immigrant communities often have this, indigenous communities as well. And so it's partly like healing is all of us together. I mean, even like thinking about it's like, it's not even just connected to people, but connected to the land or connected to nature, and again, like the Western model is also sort of like, there's this like very patriarchal, right? There's this like, there's a doctor, and you go to the doctor, and the doctor tells you what to do, and you must do what the doctor says. But the doctor isn't an expert in your body, right? Like it's also this like mechanistic view of like the body is the same, right? Which it's not. And like there are variations. And most of the studies, we did an evidence-based, double-blind, placebo-controlled study on, well, how many BIPOC people were in that study? What was the patient population? What were like you've controlled for these variables, but what about all these other variables? It doesn't really reflect the real world a lot of times. So it doesn't always, you can't just say just because the studies don't say it that isn't effective. And even if there is no data, but it's something like I believe in the power of the placebo effect. There's data about the placebo effect that and it's cheap and free. It's free. I mean, it's easy, right? So I think like, to me, I think like just the way we look at health doesn't really fit with, the way we look at medicine, I guess, doesn't fit with health in some ways, right? And I think, part of it is just like, and then the other pieces are just like, really thinking about community wisdom. And most cultures have this understanding of health and healing within their communities, right? And so individuals, like if you're living with chronic pain, you're the expert in that disease, right? So like just really bringing it back to people and to the community, and really understanding and giving them the tools that they might be able to use to kind of to heal and get to optimal well-being in some ways.
Can you talk a little bit about what you mean by colonial medicine or decolonize? What is, like, I think of colonial, I'm going to be honest, I think of like Paul Revere. Or does colonial just mean the colonization as in one group goes to another place and says, now this country in Africa belongs to Denmark or France, and now we're going to be, okay.
Yeah. Exactly. It's like, it's this idea of what's basically the idea of like mainly white supremacy. But I mean, there could be other colonial models, but it's predominantly European colonialism, where you go to other countries and you basically say, everything we're doing is right. And like, you guys are savages and we're going to like wipe you out. And we're going to like replace your models with our models, essentially. So like the models of healthcare that we use are generally European models of healthcare, while the other traditional models of healthcare that may be indigenous healthcare, or, you know, it could be, I mean, even like thinking about like midwifery, for instance, right? Like people have been having babies forever, right? Like when did it become like, oh, you have to go to an OBGYN to like... In
every culture, in every corner of the earth, if there's a person there, then there was someone who had a baby there.
Right, right. Yeah. Or using herbs, which people have figured out over thousands of years that, hey, these herbs help with these things, or whatever it is. Like these are things, but then once we moved into sort of more Western medical model, you know, it's sort of this idea that like, well, we have to use the medicines, we have to do surgery, so we have to do this, and this is the right way to do it. And so, and it just, you know, disregards like the knowledge of, you know, the rest of the communities out there, the rest of the world out there. But also like our medicine is profit driven. So like what we do often ends up being because is influenced by how can we make profits for pharmaceutical companies, insurance companies, investors, et cetera, not on how do we make a society healthy.
And the COVID vaccine is like the heartbreaking, like this argument over patents that we're going to deny, you know, because we want to make money, we're going to deny the patent release so that other countries can keep people alive. Like this is the preference is that those people die and we make more money.
Right. Yeah, exactly. Or it's not even that. It's not even you don't even think about those people, right? You're just like thinking about the money.
Oh, right. True. It's not. You're not thinking about killing people. You're just thinking.
Yeah, you're not like
they don't even exist.
They'll get it, you know. But yeah, I agree. I'm encouraged that like the Biden administration said that, hey, we're going to like talk about like potentially releasing the patent. But it's not surprising that, I mean, especially since like a lot of this funding has come from taxpayer money, you know, like, and so, yeah, there's this whole movement for the people's vaccine, which is sort of opening up the patents and creating it. But even now, like, if you look at it, like, it's not just like the access to vaccines is because the US and UK and all these countries have bought ridiculous quantities of the vaccine, which then prevents other countries from having it. And even now, like there's this talk from the executives of like Pfizer and Moderna that, oh, we're going to need boosters, which of course they're going to say they need boosters, even though there's not really any data that necessarily supports that yet, that now we're buying more vaccine. You know, like in case we need to give you boosters, instead of providing that to like the rest of the world. And the reality is like, you know, we're a global civilization. We have people coming from all over the world. You can't just have like one country protected and then have like COVID raging elsewhere. I mean, you're going to lead to variants. People are going to cross borders somehow, you know, so it just doesn't make sense. We need to be protecting everybody and making this accessible to everybody.
So with so many different people, you know, coming from so many different places with so many different traditions, when we talk about, you know, when I was in nursing school in the early 2000s and we were talking about cultural sensitivity or cultural competence, then suddenly you had to learn everybody's traditions, like what you say, what you don't say, who eats what food when, et cetera, et cetera. That sort of put everybody up against an impossible metric. So how do we think about it now? What's the right way to think about it now?
I mean, I don't know if I know the right way to think about it, but there are definitely there's research that supports other ways of thinking about it, right? So, yeah, I think you're right. The problem with cultural competency is that you're like, oh, you should learn about all these people's cultures, but how are you going to learn about all these people's cultures? And the information that you get may be completely incorrect. I mean, if you look at like, I think there was like famously like a nursing textbook that came out just a few years ago, had like all this completely ridiculous information about different cultures, like you know, like Native Americans, blah 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 blah, like, you know, Indian Americans, blah 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 blah. It's just like, that's not right, you know, like, you know, so it just basically doesn't make sense to really do that. And so there's this sort of move, and it also can actually lead to awkward interactions if, you know, or poor outcomes, or even like an othering of like people, right? So there's this movement towards cultural safety. And this comes out of like the 80s in New Zealand, as they're trying to deliver more appropriate care for their Maori population. And so the idea of cultural safety, it's just kind of rooted in the concept of power. Like who has the power in the interaction? So let's take, for example, a white male doctor. So there's at least three elements of power there. They're white, they're male, and they're a doctor, right? Because like a physician has power in an interaction generally. And so how can, health professionals that can reflect on these interpersonal power differences and make the patient feel safe? And that's the thing. So directly from the article, I have a little quote here. This is what they say. They say basically, cultural safety requires health practitioners to examine themselves and the potential impact of their own culture on clinical interactions. This requires health providers to question their own biases, attitudes, assumptions, stereotypes, and prejudices that may be contributing to a lower quality of healthcare for some patients. In contrast to cultural competency, the focus of cultural safety moves to the culture of the clinician or the clinical environment rather than the culture of the exotic other patient. So like, for example, like I always think about like from the, like recently, just, there's this whole movement of like stop Asian hate, right? Like, and it's just like stop Asian hate. And like, to me, it's like, well, we're pointing out the Asian portion of it, like, as and they don't have power in this scenario. So should it be maybe stop white terrorism? Like that's kind of like what's the root cause of a lot of this stuff. So like, who has the power and how do we adjust the power dynamic essentially? And so what do we do about it? Well, I mean, I think as practitioners in healthcare organizations, we must engage in like ongoing self-reflection and self-awareness to basically hold ourselves accountable to providing a culturally safe space, culturally safe care. And that should be defined by the patients and their communities, right? So it shouldn't be the white male doctor in that example who says that this interaction feels safe for that patient, right? So the patient needs to determine that. But some things that could be helpful, like at our clinic, we have a youth clinic and we have like a patient advisory council, which kind of helps kind of define what we want to do. I mean, you could be taking like anti-racism trainings. I mean, you could develop like an equity, diversity, inclusivity committees to examine these concepts and make changes within the organization. And like individuals need to definitely look at their biases and how it impacts the care that they deliver.
I've thought about it before, but not as directly as when you were talking about stop Asian hate. That you're right. You're exactly right. Just the way we talk about stop rape as in the rape of women, but we don't think about stop the rapist from doing the rape. Stop the rapist should be really what we're saying. And so how do we turn our attention to oppressors without discounting or dismissing victims, which is what has traditionally been done?
Yeah, I mean, that's a good question. I mean, I think that from the perspective of, let's take the Asian hate versus white terrorism. I mean, I think it's one, having this conversation and understanding what the root cause really is, right? Same thing. It's like, it's not that a woman wore a particular outfit. It's that why are we raising men who feel that it's their privilege and right to be able to do certain things, And so a lot of that is probably education starting at a younger age and really like, teaching people about these things. I mean, it's hard because, in certain ways, like when you think about like, the culture wars that we have going on right now. I mean, you have things like the 1619 Project, or we have like critical race theory and all these things. And certain people are saying like, well, we don't want to teach that. It's whitewashing. Or not whitewashing, but it's like changing history. I'm like, no, it's actually trying to give back power to those who haven't really had any power. Their history has been whitewashed for so long, right? So like, it's I don't know. I mean, in today's society, how you do that, because I think that there have to be conversations, but where's the middle ground nowadays, right? Like, where can you have conversations that aren't just one thing or the other, And I'm at a loss in our country. Like, I think social media has definitely fueled this, but I think at least acknowledging and having these conversations, like I think in healthcare, there should be a place for this. I mean, whether it's in education, like medical schools or nurse practitioner schools or wherever, to have some of these conversations and around, just the history of, white supremacy in medicine and how it impacts patients and leads to poorer health outcomes for people, or misogyny or homophobia and transphobia, all of these things, that xenophobia, and how it all impacts health, I think. So, but I don't have a good answer because, our society is the way it is. So,
Yep, I agree. Part of the reason for this podcast and part of the reason I'm thrilled to have you as a guest is because these are the conversations that we need to be having and sharing and hearing and talking about and thinking about. And I think that's how we create change. And we certainly have. It was interesting. I did in a community health class when I was in graduate school, we had to pick a population to like focus on about their health metrics. And, everybody, that was the time that people picked BIPOC people for topics, right? So then you think about poor Black women with hypertension or whatever it is. And I thought, I think I picked white rich people who live on Mercer Island in Seattle. And that was the group that I focused on, that I wanted to say, how do these people become the way that they are? Just because it seemed like the contradiction to finally have to pick a population and then you pick a marginalized population. I thought, let's just pick another population who always gets ignored when we talk about a particular population because they're the norm. So we don't think of them as a population because they're just the background. And what I found was that in the research, there were a lot of ways that people thought specifically. So for instance, when you look at race issues, people of color felt like we have so far to go and white people felt like we've come so far. So there were these ways that it wasn't necessarily right one way or the other, but because white wealthy people tend to set the tone, then they always reinforce, just like you're saying with that colonial overlay, this is the only way to think about it. And so I think changing the conversation and changing the power dynamics really can ultimately balance the power. And then we have a better society, which research has documented for a long time. Much research shows that we're all better off if our power is better distributed.
Right. Yeah. And I think you have to create more inclusive space in like leadership roles, in organizations. And you just have to, I mean, it's not just diversity. It's not just having someone there that's just like a token voice. You need to have people who are listened to and heard, and changes are made based on that. But that also sometimes you have to overcome like white fragility, which happens very easily, like, well, I'm not racist, I'm not racist. Like maybe like this as a group we are, but so it's like,
I didn't hurt anybody. I didn't own slaves.
I
didn't do it. It wasn't me.
Yeah. So that's a big challenge. But I think, again, it's having the conversations. I think there's been a movement, at least for white folks to understand their privilege, especially after George Floyd and what happened last year, where people started kind of reading more and, like looking into like anti-racist trainings and books and things like that. It's slowly moving. But I mean, there are obviously people who just are like pushing back against it. And again, that's like what I was talking about, like basically saying like, we're not going to, the Trump administration banned critical race theory from being discussed in federal governments or whatever, right? Like, and that got overturned. I think now they can talk about it in the new administration. But even just like, like seeing the woman who was involved with the New York Times, just recently, like the 1619 Project, how she was denied tenure at University of North Carolina because people pressured and said like, we don't want her voice to be like, permanently there at school. There are people in power who are pushing back and can do it because they have money and influence. Yeah. And so I don't know. I mean, part of it is like, how do you get more people with money and influence who from BIPOC communities who can then kind of like allow these spaces for people to have these conversations, I guess.
Yeah. That's a good question. If you are listening to this podcast right now, I'd like you to personally take that on. So if you're hearing this, think about, how do we share power? How do we give voice? We've made a commitment here at our podcast. So I haven't said this before publicly, but our commitment is to have more voices of color through our podcast through the entire year. Last year was our first year. I wasn't exactly sure what I was doing. So any guest that wanted to be on, I was like, great, let's try that. Right. But this year we've really focused on voices of color and not specifically just about topics that are like we're talking about, like sharing power, marginalized, it's whatever, but it's just to have voices of color talk about whatever people want to talk about, whatever their specialty is, because that seems like one way to share power, to share voice, to bring visibility.
Yeah, no, that's great. And I think that's one of the things that's kind of like nice about the democratization of media in some ways, is that you can kind of like start having your own podcast and if people want to listen, they can listen, and then, but it's at the same time, like you just create echo chambers where some people listen to these things and some people listen to something else. So I know, but at least it's giving people access and the ability to have a voice, which is nice, I think so.
So what do you see as kind of next steps for you in the work that you're doing in your clinic and integrating political and medical and healthcare? Like, what do you see coming up next?
Well, I mean, I think the question is how do we move towards health equity and justice, right? We're still always pushing for that. And I think, that concept that I really like, which kind of came out of our work with integrated medicine for the underserved. And then there are a couple of researchers at UC San Francisco, Maria Chow and Shelley Adler, and they kind of put together this paper talking about integrative health equity. And the idea is kind of like what the concepts we've been talking about, which is basically you have to to help us attain equity. Integrative health is probably one of the best tools to help us attain equity, but integrative health has to broaden its definition. It can't just be like this, we eat kale and I'm an acupuncturist, right? Like it's if we're talking about root causes, we have to look at these, upstream factors that impact health. But at the same time, we can work on an individual level with an expanded toolkit, which may include some of these traditions that are culturally relevant for our patient populations, that can work on, mind, body, nutrition, herbs, spirituality, other things that are actually oftentimes really affordable and accessible for patients, to help them sort of build resilience in their health, like we're saying, so that they can, not get sick or help manage their chronic illness. So that's one piece of it. That's the downstream portion. But then also kind of helping people at a midstream level, accessing things that they need to kind of improve their living conditions. So whether that's the medical legal partnership, or giving them access to food or transportation, or some of these upstream individual social needs. But then at the same time, working on a policy level, whether that's having people need to organize in their own communities to kind of do that, or as physicians or as other clinicians advocating on behalf of policy changes that impact our patients. So it's sort of like this multi-level approach with a broader sort of perspective that can help us sort of get to where we need to be. And so I think that's like exciting that we're kind of have started looking at things from this different lens a little bit. And hopefully it becomes a little bit more widely viewed and more mainstream. I think like individually, like at my clinic, what I think we're trying to do is trying to like take what we've done with the pain program and apply this to other chronic disease or other conditions. I mean, our program is essentially focused on, really complex trauma. And if you can take care of complex trauma patients with this sort of approach, it can apply into like diabetes or hypertension or whatever. So, we want to expand groups. We want to kind of, continue to push on this team-based approach to health. At the same time, like really, how do we tie it into like our community health workers and the work that they're doing in the community, and the advocacy work too. So I think we're trying to, kind of work on this integrative health equity model individually within our own clinic too.
And can you tell us a little bit more about I Am For Us and the conference that's coming up in September, the annual conference?
Yeah, for sure. Yes. So I'm no longer on the board of I Am For Us, but I'm an advisory member. But Integrative Medicine for the Underserved is, it's a multidisciplinary organization really focused on culturally responsive integrative health, and really helping us advance health equity and justice. And every year there's an annual conference, and this year it'll be September 23rd to 25th. It's virtual, so you don't have to actually fly anywhere. Generally, like they offer a lot, pretty affordable rates, and there are scholarships for people who can't afford it as well, which is nice. But the theme is actually decolonizing medicine toward equity and inclusivity and integrative health. So it's a lot around the stuff we've just been talking about today, but like people who are like, more of experts than me, like presenting on the work that they're doing in these areas. So it's pretty exciting. I mean, you can go to iamforus.org and kind of learn more about it. It's a great conference, and there's just some amazing talks there. So.
And can you talk a little bit about the Integrative Health Policy Consortium?
So yeah, the Integrative Health Policy Consortium is an organization that represents like over 600,000 integrative health practitioners from all the different fields out there, licensed and certified integrative health practitioners. And they kind of work for advocacy issues around integrative health. And so often they're doing a lot of work in Washington around lobbying for access to integrative health. And recently, a lot of that's been working on like pain and integrated pain management programs, and working on how to expand access, like looking at the VA and the FQHC systems, which are the federal systems that are kind of doing some of this work.
Great. So those are some organizations to look into. Are there any other resources that kind of come to the top of your mind that you'd like to share with listeners, if they're interested in what you're talking about how they can learn more or how they can access things?
Well, I mean, if you want to look up the cultural safety, there is an International Journal for Health for Equity in Health article in 2019, and that's a pretty good article. I could probably send you the link and include that in. Yeah, because that's a really good article about health equity, and it has some really good. I mean, about cultural safety, and has really good information about that.
And I want to just touch on for a minute what probably belonged earlier in the conversation, but when we talk about caring for all of us, if we are I think that there is a lot of white fragility. And so the opposite of that, or what we want to have, is essentially learn how to be a good ally. So for folks, if you are not a BIPOC person and you're listening to this and you're thinking, well, what am I supposed to do then? How do I fix it? I didn't own slaves. I'm not racist. In your mind, you're thinking that. I would recommend, number one, just recognizing your biases and continuing to work on decolonializing your own mind, like understanding where your own biases still exist. And then two is learning how to be a good ally. Do you have anything to add to that or that you'd like to say about that?
No, it's funny because the physician I work with who's done a lot of equity work, and he also used to be in the military, and he doesn't use the term ally anymore. He uses battle buddy.
Oh, nice.
Because we're in a battle. We're in a real battle.
Yep.
Right?
Yep.
It's a real struggle, and so you need someone who can kind of be there, like through the fight. So so I kind of like that term now. But no, I mean, I agree with you. I think like it's important for people to sort of to look at their self-reflect and look at their biases and don't just ask the brown person, like if there's a question, that's the
am
one
I okay?
No, it's fine. But it's sort of like, oh, what's this? Like, well, take the time to do some research. Don't just like point to the one, I always get this, like, if I'm like the only brown person in the room, like people look at me like, what do you think about this? What's the answer? I'm like, just look it up. Like don't rely on the BIPOC person to be the person who answers all your questions.
Right.
And it's exhausting. It's really tiring.
Yeah.
And we've all been through a lot. We've been dealing with racism our entire lives, and it's just to have other people that like have all these questions adding on top of that. It's just, it can be tiring. So
it can be exhausting. So, I'm Jewish, which is a little bit different than, my cultural patterns are a little bit different, but certainly I'm treated by the world as white. So to recognize, the privilege that I have, it has been a long road, a surprising road, I'll say, in the beginning, in the 90s when I started learning about this stuff. And I thought, no, I'm good. It really was like, no, I'm okay. That was the only thing that really came to my mind. And so it took me a long time to peel away those layers and recognize that, we're all good people. And sometimes we do a lot of shitty things, even to each other. And so really recognizing and working on your own material is the way to be the best battle buddy. The battle buddy in the trenches doesn't look at the person who's victimized and say, I'm so sorry that gunshot came at you. Does it hurt? How does it feel? Like you have to own whatever role you play.
Well, and it goes for other BIPOC folks. I mean, for me, I have to reflect on my own biases too. Everyone has to reflect on their own biases.
Mm-hmm.
It doesn't have to be just white people. Well,
yes.
Because there are definitely a lot of Asians and South Asians that are complicit in some of these things, even though, like, if you actually go back in the history and realize, like, as a South Asian, like, our families benefited from the civil rights movement. Like, through the civil rights bills, it allowed immigrants to come and come from other countries. And that's how my parents were able to come across and come. And so we have to actually look at our history and how are we battle buddies with Black and Indigenous and Latinos, Latinx, other folks as well, who may not also have the privilege. I mean, Asian Americans, especially Indian Americans in this country, have a lot of privilege in some ways, because a lot of times our families came who were very educated. And so we were able to move into jobs where we are able to, accumulate wealth. But we have to realize there's still a struggle. I mean, we still deal with racism on a regular basis. Mm-hmm. And, especially post 9/11, it was really bad. So I think, like, looking and like, we're battle buddies with all these people, right? We need to still, really focus on learning that history and learning how can we all move forward together, because we're stronger together than if we're separated and battling each other, right?
Yeah. And that's where that intersectionality piece comes in, where, you're of the three power dynamics that you talked about, like the white male doctor, you've got two of them. We all have, where there's going to be ways that the world says you win, you lose, and it's going to be a bit of a mess.
Right. Yeah. And I mean, I'm also like lighter skin too, right? Like versus someone from Southern India who might be darker skin. So there's that whole, there's caste, there's all these there's so much intersectionality that all.
And height and age. Body habitus. Like, there's so many things. So it's very complicated. So the idea of being in the trenches, being a battle buddy is a great description for it. We just want to help whoever we're with. Any last thoughts before we close?
No, well, thanks for having me on. I really appreciate being able to just chat and talk about these things. I think it's great that you're trying to, expand kind of what your listeners can be exposed to as well. So that's great.
Our culture around our clinic is that we're all battle buddies. That's how we think of ourselves and each other. And so knowing who we're in the trenches with, I think, is really important. And I thank you so much for coming on and sharing your story about your history and what you're doing. And Everything you're thinking about is great. Thank you.
Yeah, anytime. Thank you so much.
And thank you for listening today with Dr. Sharad Kohli. We've got lots of ways to continue this conversation through Facebook, Instagram, and Twitter. You can find more information from and about us at our website, centerforhealingneurology.com, and at the website he talks about, IM4US.org. Or even better, come see us in person at our Seattle-based clinic. Be sure to share the show with your friends, and we welcome your rating and review wherever you get your podcasts. And feel free to send topic requests to podcast@centerforhealingneurology.com. We love that you've joined us today to discuss how to make our whole world medicine. We rise or fall together, and we're committed to doing what we can to make as many of us as healthy as possible. And this takes all of us, including you. Thank you for listening, and see you next time.
Partyfish Media.
Partyfish Media acknowledges that it operates and records on indigenous Duwamish and Puget Sound Coast Salish land that is still home to the Duwamish tribe. This land is stolen in violation of the Point Elliott Treaty of 1855. We are committed to uplifting the name of these lands and community members from these nations who reside alongside us. For more information on this land, its people, or ways you can help, visit duwamishtribe.org or realrentduwamish.org.